Papillary thyroid carcinoma is the most common thyroid cancer, and its diagnosis depends heavily on morphology. In this video, we'll cover gross and microscopic features, variants, and give you USMLE style pearls to lock it in. Papillary thyroid carcinoma often affects women aged 20 to 50, and risk factors include radiation exposure in childhood and red PTC rearrangements. But on exam day, they love to ask about what it looks like under the microscope, so let's dive in. On gross examination, it's a firm, white to tan mass, often gritty when cut, thanks to the Samoa bodies. Frequently multifocal, especially in radiation cases. It commonly spreads to cervical lymph nodes, which can appear cystic. So there's a pro-USMLE tip, that is, if you see thyroid tumor with cervical lymph node metastasis that's cystic, then think it's a papillary thyroid carcinoma. Histologically, papillary thyroid carcinoma is named for its papillary architecture, finger-like projections with fibrovascular cores. But the real diagnostic clue? The nuclear features. Remember this. Number 1. Orphan annii nuclei, optically clear nuclei that looks empty. Number 2. Nuclear grooves, longitudinal folds in the nuclear membrane. Number 3. Intranuclear cytoplasmic inclusions. Cytoplasm invaginates into the nucleus. And don't forget Samoa bodies, those concentric calcifications. Mnemonic is POGI, P for Samoa bodies, O for orphan annii, G for grooves, and I for inclusions. So here's a USMLE question that you may want to try. So the question is, a thyroid tumor shows papillary structures with fibrovascular cores, optically clear nuclei, and concentric calcifications. Which genetic alteration is most likely? Just try it on your own, and the answer will be on the screen. Well, I think you've tried. The answer is red PTC rearrangement. This is the most common genetic alteration that you can see in papillary thyroid carcinoma. There are high-yield variants which you must know, like the classic variant, which has well-formed papilla with all the nuclear features described above. Follicular variant, which resembles normal follicles but still has those nuclear changes. Tall cell variant, cells are twice as tall as wide. It has a very aggressive behavior. And diffuse sclerosing variant, which has marked fibrosis, numerous Samoa bodies, and lymphoid infiltrate. So the tall cell variant has the worst prognosis, whereas follicular variant is often confused with follicular carcinoma, but nuclear features save you. Now let's get to the high-yield pearls that you need to know. The most common thyroid cancer is the papillary thyroid carcinoma. Most common after radiation exposure is also papillary thyroid carcinoma, and the one which spreads via lymphatics is also papillary thyroid carcinoma. And the one which has a lot of Samoa bodies is also papillary thyroid carcinoma. But I've made a mnemonic for some of the most common cancers that have Samoa bodies. So remember PSMM that you can get from the Samoa spelling. P for papillary thyroid carcinoma, S for serous cyst adenocarcinoma of ovary, M for meningioma, another M for mesothelioma. So to summarize, grossly, papillary thyroid carcinoma is firm, white tan, gritty, and often multifocal. Microscopically, it has papilla with fibrovascular cores and POGI nuclei, Samoa bodies, orphan annii, nuclear grooving, and inclusions. Key variants are classic, follicular, tall cell, and diffuse sclerosing. If there is lymphatic spread plus Samoa bodies, then it's probably a USMLE popular question. So remember, on USMLE, the nuclear changes define PTC, not just the papillae. Well, if this helped you, like and subscribe my channel MedHub for high-yield pathology and other medical videos. Good luck on your boards and USMLE.